Doc, we have a patient named Dina, 25 years old, married, G1P0, 34 to over 7 weeks AOG. She came to the clinic for breathlessness on climbing the stairs.
Okay. Pasod na lang siya palihog, day.
Yes, Doc.
Hello, good afternoon, Miss Nina. How may I help you today? Kumusta man ka?
Doc,
Hmm.
maayong hapon.
Yes.
Niari lagi ko kay kuan, galisod lagi ko ginhawa.
Mao ba? Kano sa pamanigasugod imong paglisod og ginhawa?
Kanang kuan mga semana naman siguro ni siya gikan karon. Lagi mga semana na niya kanang nagsugod ra man ni katong kuan ba kanang gikan ko bitaw nag-exercise kay kanang ingon magud sila maayo kuno og buros ka nya mag-exercise ka so kanang buntag mag-exercise ko nya kanang mga nakalakaw siguro kog mga 10 meters ba to niya to naglisod na ko
Kutas ka.
ginhawa.
Oh.
Dayon pag ako lang sa tong giagwantas ni uli sa ako sa apartment amo niya naaman sa second floor so kinahanglan ko bitaw nga kanang musaka sa hagdan anya kato pagsaka nako sa hagdan murag lisuda ka ayo iginhawa oy murag mo to
Sa mod.
oo.
So sukad ato hantud karon nagkagrabe gyud ang hangak nimo.
Wala man sa ningon pero naa gyud gihapon siya, Doc.
Okay. Wala ka ka sinati ani sa una katong kakaron imong first time ani?
Dili man sad, bali kuan man gud ko, Doc, atong pag 15 years old na ako kanang na-diagnose mo gud sad ko nga nako rheumatic heart disease. Unya mao to nga pagpapinatal na ako kanang gi-refer bitaw ko sa kanang cardio. Unya mao to nga kanang pag 2D echo ato nakita nga naa daw kuno koy kuan mild sa bato mitral stenosis basta murag na ako nang nikipot sa akong
Oo.
heart.
Pero kasuway baka nga na-admit ka sa una.
Wa man sad, Doc. Kuan lang gyud ko kanang asthmatic man ko pero wa man sad ko nga nagsige ka admit
Asa
niya.
na kay asthma.
Naasa ko'y asthma pero kanang mutong nitumar naman ko sa tambal niya. Kuan
Okay.
kadalas na ko nga at kay
Na-control ra na imong
kuan
asthma.
ba
Okay.
5
Pero-
years na to.
Oo.
Wala na.
Diabetes na kay diabetes, ma'am?
Wala man sa, Doc.
Yan ang high blood.
Wala sad pero kaliwat na namo.
Okay. Sige, wala ra sa kakabatig pang panghupong sa imong tiil baron.
Mausad na di ay, Doc, nga kanang kuan bitaw nga murag nabalaka kaayo ko ba kay katong 1 week na sagikan karon nga nakabantay sad ko nga pinanghupong man akong duha ka tiil.
So,
Pero
sugod
nag-observe
atong
lang sad
gibatik
ko.
nimo tong paghangak nagsugod sa tong panghupong sa imong tiil.
Ang duwag yun. Na.
Sige. Naapa kailangan gipamati?
Pag
Sige.
matulog sad bitaw ko kay pag maka-flat kay maglisod ko ginhawa so kinahanglan sad nga duha sad bitaw ka kuan, duha ka unlan akong kinahanglanon aron makaginhawa-ginhawa ko niya. Muto, di sad gid siya mawala. Ako ra siyang gi-observe for 1 week niya. Sige magbalik-balik, mausad bitaw mo nagpakonsulta ko diri, Doc. Nabalaka bitaw sad ko kay buros ra ba ko sa ni na.
Maulagi kay nang lang na nato matanaw og unsa man gay na, ma'am. So karon mag-request lang sa akong laboratory nimo o kanang mga imaging aron makita gyud nato kung sa imong problema, okay? So first, mag-request ko nimo og 2D echo aron makita nato imong kasing-kasing, ang kahimtang sa imong kasing-kasing kung naabay gyud problema. Then also X-ray para sa ma-check nato imong baga o ang imong kasing-kasing na pod. Then CBC, o ba kahilanti karon?
Wala raman sad.
Wala
I-check raman at akong temperature. Okay raman, Doc.
Sige, pasibisi lang sa tika, aron makita nato kay mura glospad ra ba katan-awon, basig anemic ka ba? So, mas maayong atong makitaan. Then, kanisang mga usual nga blood test sa mga mamdo, sama sa blood typing, sa mga infections like the HIV, syphilis, o ang imong hepatitis. Then, ato na lang sa i-check kung wala ba kay diabetes gyud, kay kaning nabi times ka kaning mga mabdos no mag-diabetes. So i-check nato imong fasting blood sugar o ang imo sang cholesterol, okay?
Sige, Doc.
Kaya ang akong
Salamat.
duda gyud ani ma'am, naay relation tong imuhang um, rheumatic heart disease bitaw sa una, tingalig nakaapekto to sa imong kasing-kasing nya karon ni grabe tungod nga mabdos ka. So mao na atong tan-awon. Sige ma'am. So balik na lang niya kung naa na imong results, okay?
Sige, Doc. Salamat, Doc.
Soon after, Dr. Lapasa consulted his colleagues regarding the case.
So, hello doctors. Thank you for coming, no? For answering my call. This is a very short notice ra kayo akong pag-contact ninyo. Anyway, ang ako manggong patient kanang I am baffled no sa iyang case kanang di ko sure. Di ko sure sa ako ang impression. So that's why I called you all to get your inputs about the case. So I think na email na nako ninyo tanan no ang case. So I hope you were able to read it na by now. So what can you say, doctors?
Well, I think Dr. Lapasad, since the patient was diagnosed with RHD 10 years ago and was also diagnosed with mitral stenosis, so I think the mitral stenosis was already chronic already.
Mhm.
So I think the primary impression for this patient is intrapartum heart failure secondary to mitral stenosis and secondary to RHD. Okay, so let's review the causes of dyspnea or breathlessness in a patient. So first, there are a lot of systems that are involved that would cause dyspnea. We have the pulmonary system, specifically if the patient has asthma or COPD, and also pulmonary hypertension, which I think that the patient has because of the manifestations that the patient has.
Mhm.
Other causes like, for example, interstitial lung diseases, also hypersensitivity pneumonia, and also bronchiolitis. Aside from pulmonary system, the cardiovascular system would also cause dyspnea. Like, for example, for this patient, the patient would probably have right or left ventricular failure, or also other causes like, for example, restrictive pericarditis or cardiac tamponade. Other systems would involve like the skeletal system, like if the patient has kyphoscoliosis, or also if the patient has the psychological disease, like not disease, but disorder, like for example, she has anxiety, so that would also cause dyspnea for
Yeah.
a patient.
Now, given all those, given your impression, Dr. Hui, what do you think is the best management? Because I think we can use diuretics, right?
Yes, exactly. Because I have read the history of this patient and also the
Mhm.
physical examination. So I think the diuretics would work for this patient. Aside, we can start the patient with furosemide since the patient is already admitted. So we can do it in an slow IV drip for this patient. Aside from furosemide or the diuretics, we can give the patient calcium channel
Yeah.
blockers. Yeah, because the calcium channel blockers would reduce the myocardial oxygen demand and also the contractility of the heart, as well as the arterial pulse for this patient. By the way, for the diuretics, that would actually reduce the preload of the heart of this patient. So we can definitely use that. And especially that these drugs are safe for pregnant women.
Okay. Thank you so much, doctors. Thank you so much, Dr. Kui, for your input. I will get
You're
back to you, doctors, later, okay?
okay.
2 weeks after, the patient came back with her laboratory results.
Hi again, Miss Nina. So, how are you? It's been 2 weeks
Um,
na, diba?
Doc, kanang ibalik bitaw ko kay nakulbaan kay kustanan kay karong buntag ba kay sakit kay akong puson niya naidigawas nga tubig niya
Unsa
murag
kadagan
dili
ang tubig?
mga tunga siguro to siya sa kuan sa cup niya kanang dili pa man unta dapat kay Hindi pa man nakabulan
Oo,
karon.
gani. Akong gitanaw. Unya kabantay ka kung naidugo.
Dok, wala man sa ko kabantay. Kung ba naging ko kanang murag tubig mo dito?
Pero wala ka na kuyapan or nahilo. Suka ba ron?
Wala man sa dok.
Wala. Sige, ayaw lang kabala ka ha. Total naa naman imong mga results karon. Ayaw lang kabala ka, ma'am niya. O okay nimo i-admit ka karon aron ma-monitor jud ka na magtarong kay no so kay nang lang yun na nato ma-closely monitor imong condition. Okay ra nimo ma-admit karon.
Okay ra, dok.
Okay, sige.
The doctors again reconvened to discuss the case further.
So hello again, doctors. So our patient is now admitted. And let's now discuss further about the case.
Okay, so for the surveillance of the patient, we have the antepartum and the peripartum. So I suggest that for our antepartum surveillance, we give the patient oxygen inhalation via nasal cannula. So 10 liters since her O2 saturation has been low, and we have to bring it up to at least 95%. We should also start or attach an IV line, giving the patient plain NSS 500 cc at a rate of 20 cc per hour. This is to help the patient with her heart volume. We have to also monitor the patient's vital signs at least every 4 hours and perform a periodic pelvic examination with an interval of 2 to 3 hours to evaluate the labor process of our patient. So we also have to, as mentioned in our previous meeting, we have to also give a single dose of furosemide intravenously, around 20 to 40 milligrams. And we have to perform, since the patients noted a vaginal discharge, we have to perform a diagnostic test, such as either your nitrazine test or your FERN test, in order to confirm the rupture of the membrane, that the fluid is actually amniotic fluid. Okay. So lab tests that we would request, we would get an CBC to rule out the possible anemia, and infection. We would also get a routine urinalysis and INR. We also have to administer a single dose of your corticosteroids. In this case, I think it would be best to give your betamethasone, 12 milligrams IM. This is to ensure fetal lung maturity of the fetus, since the patient is 36 weeks AOG. She should also be put NPO for at least 6 hours, and the patient should be advised to lie in a lateral recumbent position. So this position is to avoid the overt aortocaval compression and its potential lower uterine perfusion. So for peripartum surveillance, we have to evaluate, of course, and record the fetal heart rate of the fetus every 15 minutes after a contraction. So we also have to monitor the mother, the patient's vital signs every 4 hours again, and evaluate her temperature to make sure that there is no infection, since she already has a ruptured membrane. We have to also insert a bladder catheter and administer antacids in order to avoid acid aspiration syndrome. For her analgesia for the procedure, what is suitable for the patient, I believe, would be epidural analgesia. So this is because it is used in nearly 70% of mothers with a success rate of 98.8%. So also, labor and delivery is particularly stressful for women who have symptomatic mitral stenosis, which we all saw in her 2D echo, right? So uterine contractions in these patients increase the cardiac output there, and then this further increases the circulating blood volume. So again, this is ideal for labor for these types of patients, the symptomatic mitral stenosis. For the antibiotic coverage of this patient, since she has a ruptured bag of water, intrapartum chemoprophylaxis is, we should perform that. This is based on the mother's allergic history and the susceptibility of the isolates possible. So we should give an intravenous dose of ampicillin It should be administered at least 6 hours before the delivery of the fetus. This is in order to ensure maximum effectiveness. So, for the route of delivery and the manner of delivery of the fetus, I think what is best for the patient and for the fetus is that we perform an operative vaginal delivery. So again, an operative vaginal delivery, these are vaginal deliveries accomplished with the use of forceps or a vacuum device. And then, as we all know, some maternal indications for performing this kind of delivery is that patients with heart disease, pulmonary compromise, intrapartum infection, and certain other neurological conditions. Most commonly, we are the exhaustion of the patient and prolonged second stage labor.
So, hello nurse. Ako di si Dr. Christine Singh, resident ko under ni Dr. Lapasa. Mangayon ta kog update sa among patient, si patient Nina.
Patient Nina, Doc, for a while, Doc, ha? Okay, patient Nina.
Take your time.
Nara, Doc. So we have patient Nina. 6 hours after the first IE sa patient, Doc, she complained of bearing down sensation. And then we repeat the IE. This time, the cervix is already HCM dilated at station 0. Then 8 hours after, we repeat IE again. Cervix was fully dilated and effaced at station +2. And patient underwent of operative vaginal delivery via forceps delivery. And then patient lost 700 cc of blood postpartum. No?
I know, daghan day siyang dugo nga nawala. So, kuan ato na siyang ibutang sa ICU for close monitoring. And then, mag-administer na sa taog IV fluid for resuscitation para ma-avoid ang hypovolemic shock kay common na sa kanang daghan kayong blood nga nawala sa delivery. Then, i-monitor sa nato iyahang circulatory kanang kuan if normal ra ba yang vital signs, dili ra ba ubos kay prone sad na sila magka-circulatory compromise.
Okay, Doc. Sige, Doc. And kuan de, Doc, ano mo tana ang patient if kuan niya ma-breastfeed ang baby?
Actually, wala ra may mga contraindications ang atong patient kay kuan pwede ra siya maka-breastfeed kay wala man sad siya history of kanang drug use and kanang alcohol, and then wala sad siya infection sa iyahang walay galactosemia, wala sad dili sad siya HIV positive, unya wala sad siya nag-use og breast cancer na treatment. So pwede ra jud kaayo siya mag-breastfeed. It is i-advise jud na nato at least 6 months gani kay pwede siya mag full breastfeed ra na time.
Okay, Doc. Thank you.
Thank you.
2 days postpartum, Dr. Singh followed up on patient Nina's case.
So, hello nurse. Ako day gyapon si Dr. Singh. So, balik ko diri kanang mangutana about patient Nina's case o iyang progress.
Okay, Doc. So, patient Nina, Doc, 2 days postpartum, patient developed fever and chills. Iyang temp is 39 degrees Celsius. Then breasts were engorged. Vital signs, blood pressure 100/70, heart rate 106 beats per minute, respiratory cycle of 24 cycles per minute. Then for the genitourinary, Doc, edematous perineum with intact episiotomy wound. Bimanual pelvic examination, Doc, warm introitus, moderate, slightly foul-smelling lochial discharge, hyperemic and swollen sutured vaginal laceration at 7 o'clock position. Cervix admits 1 finger, enlarged clitoris, and non-tender, Doc.
So ato lang ni siyang i-close monitor kay basin nag-suspect ko nga na siya sepsis pero i-confirm sa nato siya.
Sige, Doc.
Thank you, nurse.
Thank you, Doc.
The doctors resumed their conference.
So hello again, doctors. Dr. Singh here will update us about our patient's case.
So our patient, she was admitted to the ICU because due to the complications after postpartum. So she was febrile and tachypnic, and then on her bimanual pelvic examination, the vaginal laceration at 7 o'clock position were hyperemic and swollen. So I'm suspecting that there is an ongoing infection. So doctors, can you help me in coming up with a diagnosis of this?
Okay, so at this point, with taking into consideration everything that the doctors have said and um, her physical examination, history, and everything, our working diagnosis at this point would be sepsis secondary to puerperal pelvic infection. Okay, so puerperal pelvic infection is any bacterial infection of the genital tract after delivery. Okay, so we ruled this in because first, the patient had fever with a Tmax of 39 degrees Celsius, and there's chills. Also, the patient is tachycardic at 106 beats per minute. She's tachypnic at 24 cycles per minute, and there is presence of foul smelling vaginal discharge. Also, that there is enlarged uterus. I think at this point now that would be all. So it is correct to assume that this is sepsis secondary to puerperal pelvic infection. So I think it is important also to discuss now the care that we will do for this patient starting from immediately after delivery. So of course, the vital signs are important. Vital signs monitoring. So blood pressure and pulse are taken every 15 minutes immediately after delivery. And then, of course, the temperature is also assessed every 4 hours. And the amount of vaginal bleeding is monitored. And the fundus is palpated to ensure that it is well contracted. So if there is relaxation, if relaxation is detected, the uterus should be massaged through the abdominal wall. Also, the uterus should be closely monitored for at least 1 hour after delivery, since most frequent cause of your obstetrical hemorrhage is failure of the uterus to contract, and we don't want that. So we could also administer uterotonic agents to reduce postpartum hemorrhage. We can use 20 units of oxytocin in 1,000 ml of crystalloid solution given through IV at 10 ml per minute for a dose of 200 millunits per minute. So postpartum, we should also do intensive fluid resuscitation, since our patient lost a lot of blood, to avoid hypovolemic shock or circulatory compromise. We can do this. We can start crystalloids. We should also secure blood derivatives, although we don't have laboratory results yet. We don't have CBC, but it is important to secure blood derivatives in case the patient will need it. And also oxygen therapy. So we should also, since our working diagnosis here is already sepsis, so we should administer the gold standard IV therapy, broad spectrum antibiotics. Okay, we should use clindamycin, gentamicin regimen once daily, plus ampicillin, since there is already sepsis. So for the hospital care, we have your perineal care to further ensure that there will be no other sources of infection. And of course, for dietary restriction, since our patient delivered vaginally, So after 2 hours, she is allowed to eat. So it is also important to review the normal changes that is happening to the reproductive organs. To assess the abnormal, we should first assess the normal. Now, so what is the changes that occur in the reproductive organs of the patient after delivery, during the puerperium. So the puerperium is the period of about 6 weeks after childbirth, wherein the mother's reproductive organs return to their non-pregnant conditions. So first we have the uterus. So what happens to the uterus is it normally shrinks to non-pregnant size during the first 6 weeks postpartum, but reduction in size and weight begins in the first 2 weeks. So the inner lining, or your endometrium, after birth also heals, so as by the seventh day it is restored throughout the uterus except for the placental site. So there's also reduction in the number of your capillaries, and the lochia also continues for several weeks. But for the first week, of course, it is bloody and brownish, but for the next 2 to 3 weeks, it gradually decreases and it becomes straw-colored. So next is the cervix. So immediately after delivery, the muscular walls relax, it thins and it stretches, and it may also appear swollen or bruised. That is normal. And for the first day, it narrows and regains its normal muscular consistency. So 24 hours after delivery, the cervix should be at least 2 fingers in diameter. And for the first week of postpartum, it should be 1 finger in diameter. So next is for the vagina and the vulva. It also gradually shrinks to the non-pregnant size about 3 weeks after birth. The swelling and the increase in blood flow also disappears. So sexual intercourse may be resumed, but also we should take into consideration the physical and emotional preparedness, or if the patient is ready to have sexual contact again. So for the perineum, most of the muscle tone and the strength is regained by 6 weeks. And then lastly, for your ovaries, the resumption of normal function is variable, and it is greatly affected by, it is greatly influenced by breastfeeding. So for exclusively breastfeeding mothers, there is longer period of amenorrhea and there is delayed ovulation. No? So next, okay, we will now talk about puerperal fever. So these are fever lasting for more than 24 hours within the first 10 days after giving birth. So since we've established our working diagnosis, we will also discuss our differentials. So first, we will first consider your postpartum metritis with pelvic cellulitis. So this is the inflammation of the uterus, and we ruled this in because first, we have fever. Second, our uterus is enlarged. Third, we have foul discharge. And we rule this out because there is no abdominal pain and there is no uterine tenderness, which is usually present if the patient has metritis. Next is our septic pelvic thrombophlebitis. So this is the presence of your endovascular thrombus in the setting of associated bacterial or fungal infection. And the most common in the setting of childbirth is your ovarian and your pelvic vein, pelvic or ovarian vein, STP. And this occurs usually in the first 3 weeks postpartum. We ruled this in again because of fever. And then the patient has foul smelling discharge. there and the patient is tachycardic. However, this is a diagnosis of exclusion. So we should first rule out the other possible causes of puerperal pelvic infection before we consider your septic pelvic thrombophlebitis. Next would be your postpartum acute pyelonephritis. So this happens when the bacteria ascends from the bladder. So again, we consider this because of fever, chills, and however, your flank pain, which is characteristic of your pyelonephritis, is absent, and the patient had no urinary symptoms like frequency in urinating, urgency, dysuria, hematuria, so we don't have that. So next are the common causes of your puerperal fever. According to Williams, the most common is your genital tract infection. However, it also occurs in the setting of your urinary tract infection, your infection of perineal laceration, infection of episiotomy site, and infection of abdominal incision in the case of CS patients. It also occurs in physiologic settings like your breast engorgement. However, in physiologic cases like that, the fever does not usually reach 39 degrees Celsius, and it lasts for less than 24 hours. So we're not considering that. So next is, we're done with the differentials. And next is, since we've mentioned antibiotic therapy, we should also discuss or just mention the possible reasons why a fever persists despite antibiotic management. So first, it might be because of antimicrobial resistance. This is fairly common nowadays, and it is a growing challenge. So that's self-explanatory. Next is inappropriate antimicrobial treatment. So it could be caused by your Clostridium, and then we did not administer metronidazole. So like that, there is wrong choice of antibiotics, wrong dose. There are a lot of things to be considered, or there's delay in initiation of appropriate antibiotics. So it may be correct, but there is delay. With that increases our mortality. Also, it might be a side effect of the drug itself. So the fever might be because of the drug itself. What do you think, doctors?
It's good, actually. It's a very good impression for this patient.
Thank you so much for your input, Dr. Albishi.
Review of antibiotic coverage was done and patient was managed aggressively. Additional antibiotics were given. Breast care, including use of breast pump, was encouraged. Perineal wound care and perilite exposure was done regularly. Patient improved and was discharged on the 7th postpartum day.
Hello, doctors. So now we are ready to discharge our patient because she is now well and improving. The vitals are now stable. So what advice or patient education can you give or can we give to our patient?
Since breastfeeding is not contraindicated in this patient now, we can educate the patient regarding the steps for successful breastfeeding, including its advantages. So contraceptions can also be discussed prior to discharge of the patient and after postnatal checkup 6 to 8 weeks after giving birth. So there are different types of contraceptions. First, we have your intrauterine device, progestin implants, progestin-only contraceptives, which can be started 6 weeks postpartum for breastfeeding women or immediately prior to discharge for non-breastfeeding women. We also have hormonal contraceptives and barrier methods, which includes male condoms, female condoms, diaphragm clasps, spermicides, and cervical caps. So the contraceptions that I can recommend for this patient includes combined hormonal contraceptives, progestin pills, implants, or depot methoxyprogesterone acetate. So there are medical eligibility criteria for contraceptive eligibility, which includes category 1, a condition for which there is no restriction for the use of the contraceptive method. So this includes the recommendation for combined hormonal contraceptives for women from menarche through 40 years of age. Category 2, a condition where the advantages of using the method generally outweigh the theoretical or proven risks, which is an example, which includes the recommendation for CHC for women 40 years or older. Category 3, a condition where the theoretical or proven risk usually outweigh the advantages of using the method, which is true in cases of breastfeeding women who are more than 48 hours to less than 4 weeks postpartum should not have an IUD inserted. So lastly, category 4, a condition which represents an unacceptable health risk if the contraceptive method is used, which is true in cases of women with breastfeeding and non-breastfeeding women with puerperal sepsis should not have IUD inserted, which is why I did not recommend IUD insertion for this patient.
Thank you so much, Dr. Sanchez, for laying out all the possible contraceptive options for our patient, as well as talking about breastfeeding. Now that we've reached the final part of this discussion, I would like to ask Dr. Singh, what do you think is the final diagnosis?
Having to hear all the discussion from our previous conference and meetings that we had, so I've come up with a diagnosis of sepsis secondary to puerperal infection and heart failure secondary to mitral stenosis secondary to rheumatic heart disease.
Okay, so Dr. Singh, can you elaborate to us further and discuss how did you come up with this diagnosis?
So first, having to hear all the discussions that we had. So for the first is for sepsis secondary to puerperal infection. Since we noticed that the patient had a ruptured bag of water already, and then which is prone to infection. So and then postpartum, she delivered the baby, and then postpartum she experienced bleeding. So she was admitted to the ICU and lost about 700 cc of blood during that time. So the ruptured bag of water may have caused the secondary sepsis to the patient, and then which we can, as we can see that there was already hyperemic laceration. And then next is for the heart failure secondary to mitral stenosis secondary to rheumatic heart disease. So the patient on her history, she had a rheumatic heart disease at the age of 15 years old, which is prone to develop or common in patients with who have mitral stenosis. So in her history, there was a grade 3 holosystolic murmur at the apical area. So this mitral stenosis will present their scarring and fusion of the mitral valve, wherein it increases the pressure in her left atrium, which causes pulmonary congestion towards the lungs. So in here, there will be backflow of blood, which leads now to the presentation of the patient of right-sided heart failure, since she manifested positive net vein distension, and there is also grade 2 bipedal pitting edema. So with that, I think that is our final diagnosis.
Okay, thank you so much, Dr. Singh. Very good. So thank you so much, doctors. I think that this is now the end of our discussion. Thank you so much, Dr. Singh, Dr. Albishi, Dr. Hausen, Dr. Sanchez, and Dr. Kui, as well as, of course, our narrator, Dr. Asensi, Dr. Asensi, and of course, our ICU nurse. Where is our ICU nurse? Nurse Falmark. And of course, our patient. Our patient, where is our patient? Miss Nina. All right, there is Miss Nina, all freshened up. Okay, thank you so much, everyone.